Hi everyone, I'm Monica Perez from Shirley AbilityLab, Northwestern University, and the Heinz BA in Chicago. So I want to thank the organizers for inviting me to be part of the meeting to discuss perspectives on spasticity following spinal cord injury. So in the United States, we have over 300,000 people that live with a disability that is related to spinal cord injury. Importantly, we have continued to have over 18,000 new cases of spinal cord injuries every year. The majority of individuals with spinal cord injury develop spasticity. Depending on how do we do the assessment of spasticity, we have evidence that around 60 to 70% of cases develop spasticity, and 30 to 40% of cases do not develop spasticity. And this is quite important for us to understand the neural mechanisms of spasticity and assessments of spasticity. So what is spasticity? And I think this is a very important question, and I'm going to try to clarify a little bit the definition that we have been using for several years in our laboratory. So Lance, in 1980, defined spasticity as a motor disorder that is characterized by a velocity-dependent increase in tonic stress reflexes with exaggerated tendon jerks resulting from hyperexcitability of the stress reflex. So this is the definition that we usually use in our testing with patients with spinal cord injury in our research protocols. However, it is important to highlight that the definition of spasticity has been broadened over the years and challenged also over the years, opening to the consideration of including multiple symptoms of upper motor neuron lesion when we refer to spasticity. And it's extremely important to consider which definition of spasticity we are including in any particular condition, because for some groups, the definition of spasticity can include spasms, clonus, and other symptoms of hyperreflexia. But the definition that I will be using today during my presentation is hyperexcitability of the stress reflex. So today I'm going to focus my presentation on two main areas, and is the assessment of spasticity, and I'm going to show you two examples of how can we complement our clinical assessments by using either kinematic analysis or also by using a dynamometer and electromyography. And in the later part of my presentation, I will discuss a possible role of spasticity as a biomarker in recovery of function of patients with severe spinal cord injury. So let's go to kinematics. So usually we quantify spasticity in the clinics by using the modified Ashworth scale. On the left side of the screen here, you can see this is a nominal scale that is widely used by clinicians to characterize spasticity. And the score goes from 0 to 4. 0 means no increase in muscle tone, and 4 means that the affected part is rigid. So you can imagine, by using a nominal scale, the level of sensitivity that we have is limited, and also the ability to detect asymmetries between the left and the right side is also limited. So we have been using in our studies another methods to complement this clinical assessment. And one is the use of kinematic analysis and sensors during the pendulum test. And this is an individual without a spinal cord injury, and one of the researchers in our group is going to drop the leg. And I just want you to look at this video and see how the process and how the test is being done. So if we drop the leg, there's no resistance opposed to the movement. However, in contrast, we have on the lower part another video of a participant with severe spasticity in the quadriceps muscle. And if we drop the leg, you can see clearly that there is a catch during the movement, and there is a resistance opposed to the movement. And we can quantify this by using kinematic analysis. So this study was recently published last year in the Journal of Neuroengineering and Rehabilitation, and the study was led by Dr. Dalia DeSantis in our laboratory. And we developed a portable system to actually assess spasticity during the pendulum test. So we did analysis and we compare our optical tracking system. So we have different markers that you can see, and we use two IMUs, two sensors that were positioned in the upper part of the leg and in the lower part of the leg. And we completed measurements during the pendulum test in consecutive days. So this is what we found. This is the original position that we used during the testing. Participants were in the semi-reclined position. We standardized the position of the trunk, the position of the leg during the pendulum test. And we used exactly the same position during testing of the modified Ashworth scale. And simultaneously, we measure kinematics analysis, and also we use the sensors. So these sensors, these are the sensors that we use. This is the location of the two sensors. And our engineer developed a software that actually is quite easy to use and could be installed in any computer, where the therapists or clinicians can actually move the leg to the horizontal position and then drop the leg, and we can quantify the first swing angle and the number of oscillations that the leg performed after completing the test. So what did we found? We found that spasticity, actually, the two measurements were quite reliable and quite sensitive to detect changes in individuals with spasticity. So this is raw data from a control subject, and the black line and the dotted orange points show you data in 2 consecutive sessions, and also data using these 2 different systems. So you can see a clear difference between this individual with spasticity and the individual without spasticity. And this is the group data, and you can see that we found very much agreement between the 2 measurements using the 2 systems, but a clear difference using between patients or participants with spinal cord injury and control subjects, suggesting that this methodology, these new sensors, are sensitive enough to complement the clinical exam. Then when we compare the analysis on 2 consecutive days, we observe something very similar. You can see that there is a large agreement in the measurements detected by the tracking system or by our cameras, and also the sensors that we use in day 1 and day 2. In control subjects, there is a large agreement between days, between the measurements obtained across days, and also in individuals with spinal cord injury, you can see that there's more dispersion of the variables. So this is the group of participants that present spasticity, and this is the group of participants with spinal cord injury without spasticity. So we correlated these measurements with the clinical exam, with a modified Ashworth scale, and you can see in red are individuals without spasticity, and these are the different colors that are coding the different degrees of spasticity that are detected by the clinical exam. So you can see that there is a large, strong association, particularly when you detect strong spasticity with the clinical exam. You can clearly correlate those values of what we are observing with our sensors or our kinematic analysis. There is an area where there is it's hard to find an agreement, and this is the area where the sensors add more sensitivity to the clinical exam. If the spasticity is very severe, there is a large agreement, but when the spasticity is less severe, the use of these sensors is quite important to increase the possibility of detecting spasticity. So how can we use other methodologies to also detect the spasticity? So we have been using also a dynamometer and electromyographic activity in order to assess spasticity. And I'm going to show you one example. And this work was led by Dr. Bing Shen, who is working with me in Chicago. And what we did is to assess spasticity now in plantar flexor muscles. So we use this the dynamometer that we use electromyographic activity, and we stretch the plantar flexor muscles at 2 different velocities. This work was published a couple of years ago in the Journal of Neurophysiology. So you can see here that this is data in a control individual, and we stretch approximately at a very low velocity, 20 degrees per second, and the 2 lines here show you the left and the right foot. And during the stretch, this is a passive torque that is detected. So this is what we normally detect and during a stretching at this velocity in control subjects. This is a representative individual with spinal cord injury. So if we stretch the plantar flexor muscles at this velocity, you can see that the resistance during the stretch is much more pronounced. And there is a difference also between the left side of the body and the right side of the body. So there's 2 things that are changing following spinal cord injury that can be detected by these more sensitive assessments, which is asymmetries between the left and the right side. And there is part of the resistance that is not coming from a reflex mechanism, but comes from passive properties in the muscle. So at the same time, we also conducted a next trial when we stretched the plantar flexor muscles at a higher velocity, approximately 300 degrees per second, and to ensure that we can elicit a stretch reflex. So this is how a stretch reflex looks, and this is in the left side, the left plantar flexor muscles. We recorded this electromyographic activity from the soleus muscle, and this is the right side. So you can see that there's no asymmetries. The size of the reflex is quite similar between the left side and the right side in control subjects. However, in people with spinal cord injury, you can see that the size of the reflex is larger and is much more pronounced in one side of the body compared to the other side. So this is what the group data is reflecting. The stretch reflexes are smaller in control subjects, and there's no asymmetries. However, in people with spinal cord injury, the amplitude of the stretch reflex is larger, and there are asymmetries between the left and the right side of the body. So this is where these more sensitive assessments are very important in our quantifications of spasticity. If we use the clinical exam, for example, in the same number of participants, in this study, we tested 24 participants with spinal cord injury. If we use the clinical exam and we test the modified Ashworth scale in the plantar flexor muscles, you can see that the majority of subjects had some spasticity, but we were not able to detect too much asymmetries. Indeed, if we look at the 100% of the patients that we tested, asymmetries were detected only in 25% of the cases. However, if we use the dynamometer, we were able to detect asymmetries in 92% of the cases, suggesting that this type of equipment is more sensitive and is important to be used to complement what the outcomes are of the clinical exam. Even we had a questionnaire, we had a standard questionnaire, and you ask patients, do you have more spasticity in the left side or the right side of your body? And they were accurately to detect if there was more spasticity in one side of the body compared to the other side. So these type of methodologies are extremely important, are available today, they're easy to use, and can be quite important to complement what the clinical exam is giving us in terms of assessments of spasticity. So why do we think assessments of spasticity are so important? We have a little bit of evidence that the presence of spasticity can represent and can become a good biomarker to predict recovery in patients who have a very severe spinal cord injury. So this is tissue from 3 individuals who had a spinal cord injury. And I'm going to walk you through these images. This individual had a contusion injury due to a motor vehicle accident. This is tissue from the cervical spinal cord. And this individual had a contusion injury at the high thoracic level, also due to a motor vehicle accident. And this individual had a laceration in the lumbar spinal cord due to a gunshot. So if you look at the images, all spinal cord injuries are quite different, but regardless of that, there are some similarities between them. For example, injuries are bilateral, okay? Both sides of the spinal cord are affected. Injuries are asymmetric. In this case, you can clearly see that one side of the spinal cord, there's more massive loss of tissue compared to the contralateral side. This is also very clear here when there's more massive loss of tissue in one side compared to the other side. So this is important because our clinical exams also in many occasions reflect these asymmetries. And some asymmetries are not as clear as others, but this equipment, this sensitive equipment that I showed you before, can allow us to detect these asymmetries and better assess spasticity. So what is the relationship between these residual connections? If you think about the spinal cord, there is massive loss of tissue in the center of the spinal cord, but you still have a number of residual connections, and this is where the location of the descending motor pathways are, and that are still present after the injury. So we have good evidence, even from the early 70s, that there could be a connection between those residual connections after spinal cord injury and the presence of spasticity. So Milan Dimitrijevic in early 70s and published several studies suggesting that there is a potential relationship between spasticity and recovery. Spasticity was present in patients with spinal cord injury who had evidence of residual or subclinical suprasegmental influence on spinal pathways. In other words, these were people with discomplete injuries. So we decided to test this hypothesis. In those years, we didn't have a way of stimulating the brain or the primary motor cortex and actually assessing connections from descending motor pathways. So, and this work was published in 2019. And the work was led by one of my senior fellows in the lab, Dr. Sina Sangari. We stimulated the leg representation of the primary motor cortex by using transcranial magnetic stimulation, and we had recordings, electromyographic recordings on the quadricep muscle, and we also used MRI analysis to assess the volume of the spinal cord. So it's important that in this testing, in this study, we tested only patients who have a motor complete spinal cord injury, very severe injury. And we detected, as the statistics before that I show you suggest, that the majority of participants have spasticity. 60% of them presented symptoms of spasticity, and we used the pendulum test that I described before and the modified Ashworth scale for these assessments. And approximately 40% of them did not show symptoms of spasticity. So what was very interesting is that we had two groups of patients, and I'm showing you some important representative data. In red, you can see the group of some representative individuals with spasticity. This is the number given by the modified Ashworth scale. This is the location of the injury. And in all these participants in red, we were able to detect the presence of residual connections when we stimulated the leg representation of the primary motor cortex. You can see that these connections are there, clearly there, but in individuals without spasticity in green, we were not able to observe those connections. Importantly, these connections, we conducted a second study in order to understand if all patients with these complete injuries have these connections. So we found 3 groups of patients. Group 1 had a spasticity in the quadriceps and in the soleus muscle. Group number 2 had a spasticity in the quadriceps, but not in the soleus muscle. And group number 3 had no spasticity in both muscle representations. So what we observe in terms of connectivity is that group 1 had connections in both muscles, group 2 connections only in the quadriceps, and group 3 no connections between both muscles. So the pattern of connectivity was very much in agreement with the pattern of the presence of a spasticity, suggesting that there could be a relationship between these 2 variables. Then we decided to test the hypothesis, can then spasticity be used to predict recovery in those patients? And we tested patients at Shirley Ryan AbilityLab, 2 groups of patients, some with motor complete spinal cord injury, very severe injuries, AIS A and B, and we tested people with incomplete spinal cord injuries. We took measurements soon after they get admitted to rehabilitation and before discharge from rehabilitation. And this is what we found, which is quite important. The group of patients with very severe spinal cord injuries who had a spasticity, who are the people right here in green, were the ones who show some recovery in the INSCI exam. This shows you the improvements in points in the INSCI exam, in the motor component of the INSCI exam. People who did not have a spasticity and had a very severe injury did not show evidence of motor recovery, supporting our hypothesis. This is another representation of the data. You can see that the motor complete group that had a spasticity shows some recovery, but the motor incomplete patients did not show this association. So we are currently conducting a large clinical trial throughout the United States. This is funded by Neidler and is a collaboration with Dr. Alan Heinemann, David Shen, Alison Kessler, and others. And we are testing this hypothesis. We have collected data of over 115 patients by now, and we're hoping to finish that study in the next couple of months. And the hypothesis is that spasticity will be a possible predictor of recovery in those patients with more severe spinal cord injury. So I have shown you some evidence that clinical assessments of spasticity and sensory function during spasticity can be complemented by using available methodologies like kinematic analysis or dynamometers that are quite sensitive and available today. And more sensitive information can be used or acquired in terms of the intensity of the system. How prevalent is spasticity? How strong is spasticity? And how asymmetric is the presentation of spasticity? So I want to thank all the lab members that are working with me in Chicago and the funding agencies that have been supporting our work for several years. Thank you very much.